Hi, I'm Gavin Giovannoni, Professor of Neurology from Bart's MS. I'm just going to give you a short presentation of a presentation I did at ECTRIMS in Paris just over a week ago on the effects of Natalizumab on lower and upper limb function in people with secondary progressive multiple sclerosis using a new method to analyze the data. I'd like to thank my co-authors, the participants in the study, as well as the steering committee members who allowed me to present this data. We do have a large number of disclosures, and I will put up this presentation on my SlideShare site for you to download to read later. The ASCEND trial involves people with secondary progressive multiple sclerosis, and they were treated with natalizumab with the primary outcome to try and delay the disability progression using a multi-component endpoint. And the components were the EDSS score, time 25 foot walk, and the 9-hole peg test, a upper limb function outcome. This was a fixed duration trial of 2 years. Once the patients finished the 2 years, a large number of them were pushed into an extension period before the trial was actually stopped. Now, the overall benefit of natalizumab can be viewed as a combination of worsening disability as well as improvement, and to try and capture the improvements which aren't necessarily measured in the primary outcome measure, I'll be proposing using what we call an area under the curve analysis. Why this is important is because we've recently put forward this hypothesis, which we think is now pretty well established, that MS is a length-dependent axonopathy. In other words, the length of the nerve fiber dictates which systems get affected first in more advanced disease. So the nerve fibers to the lower limbs are much longer than to the upper limbs, and therefore they will acquire more hits over time, and therefore more likely to degenerate early and present with progressive disease in the lower limbs. This means that pathways like to the upper limbs that have more reserve capacity have the greater ability to recover or repair function, and this will be missed in an outcome measure that only tracks worsening of disability. So we think the area under the curve analysis is very useful. So the primary outcome of this analysis was to look at the area under the curve analysis and all three of the components, EDSS, time 25 foot or 9-hole peg test. This is the study design. As you can see, people were screened, randomized to either placebo or 300 milligrams of natalizumab given as an intravenous infusion every 4 weeks, and they were assessed up until 108 weeks. Importantly, this was a much more advanced population. People had to be between 3 and 6.5 on the EDSS score and had to have diagnosed secondary progressive multiple sclerosis for at least 2 years, and the age range was from 18 to 58 years. The majority of people in the trial, that 71%, had not experienced a relapse in the prior 2 years. And that means these patients were, in inverted commas, as pure a progressive population as possible. And over 60% of these patients had really lost a lot of lower limb function, and they were EDSS 6 or higher. In other words, they were needing walking aids. Now, the area under the curve methodology, we use a trapezoidal method. It simply calculates the area both below and above the line, in other words, improvement and worsening, and integrates this into one score. What you've got to realize is in clinical trials, the way we do them now, the improvement that occurs particularly early in the course of the disease won't be captured in our outcome measures, and we only look at worsening. And this is the primary result. As you can see, when you do the mean area under the curve, you can see a major treatment effect, particularly in the upper limbs, with a 77.2% reduction in area in the natalizumab treated patient compared to placebo. When it comes to the lower limbs that have less reserve, using the time 25 foot walk, it's 28%, and there was no real significant difference in the EDSS. And so what this picture tells you is the upper limbs are much more sensitive to change compared to the lower limbs, and the time 25 foot walk is a much more sensitive outcome measure than the EDSS. Now this next slide is another way of presenting the results, looking at the percent change from baseline in the area under the curve analysis. And what you want to look at is the light blue being placebo and the dark blue being natalizumab. And you can see that there is a left shift in terms of the treated patients with natalizumab compared to the placebo. And so people with secondary progressive disease on natalizumab have much greater improvements compared to people on placebo. And so this would be a shift of the curve. This is the same analysis now done for the timed 25-foot walk, and you can also see a shift to the left in terms of natalizumab-treated patients. They're more likely to improve and less likely to worsen, but it's not quite as dramatic as the previous 9L peg test. This 9L peg test, timed 25-foot walk. So in conclusion then, this is a post-hoc analysis from the 2-year randomized treatment period of the ASCEND trial, using a new methodology that integrates both disability worsening and improvement outcomes. And based on this, you can see the disability improves significantly in walking and upper limb function compared to placebo in a population of patients that is non-relapsing. Also, the placebo, compared to placebo, natalizumab-treated patients were likely to reach thresholds of increased area under the curve disability, which indicated a net worsening of disability from baseline, and were more likely to reach thresholds of decreased disability, which indicated a net improvement in disability from baseline. These results are entirely consistent with the primary results from the ASCEND, with the greatest effect on upper limb function, where there is more reserve capacity. And I think these results give us insights into how we should be doing trials in more advanced disease. I think we should be developing outcome measures that capture both improvement and worsening, and a bigger focus on upper limb function that has more reserve than lower limb function. And what this trial does tell us is that the EDSS is a flawed outcome measure for more advanced disease. It's much less sensitive to change and does not capture significant change over a period of time. So for us to do reasonably powered, quick trials in more advanced disease, we really need to get rid of the EDSS from our primary outcome and focus on more responsive methods, particularly upper limb function. And I would like to thank you for listening.